and we are back here live on the Compliance Guy Auditing, Coding, and Compliance Roundtable. I almost forgot the name of the program because it's been so long since we've been
I
together.
know.
But hey,
I don't even remember the last time I was here. It's
yeah,
bad.
well,
I do. I was in
see,
Hawaii in
Terry keeps
Oh,
May,
track of
and my
all this.
husband was
okay.
bringing me a cone of coffee from behind me.
Yeah.
Paul was like, "Really? Where's mine?"
Well, today I have Terry, Paul, and Stephanie joining me right now. Scott Kraft has indicated he will be jumping on here in the next couple of minutes to join us live as he finishes up a provider training session. But I wanted to say real quick, because we haven't done one of these since I was out for surgery. I cannot tell you how much I sincerely appreciate not only all of the well wishes that you guys posted to LinkedIn, but the I was so overwhelmed. It's got to be more than 100 DMs and emails and things just wishing me well. Sincerely, from the bottom of my heart, even if I've not personally reached out to each and every single one of you, just know that I have read every one of them because I've had a lot of time on my hands to be able to do that over the last couple of weeks. It means the world to me. I cannot thank you all enough, and just glad to be back. Got my bionic robotic arm working here, and hopefully things keep trucking along for me. So, with that said, enough about me because this program's actually about the experts, Terry, Paul, Stephanie, and when Scott arrives. So we've got a great program lined up for y'all today. Before we got going live, uh, we started having a little bit of a conversation about what's going on with CMS going after the healthcare organizations that are third party administrators for the government that are working on HCC coding and the problems that have arisen, the problems that currently exist, and the problems that will most likely exist in the future. So, Paul, it was a great topic that you threw out to us this morning. I want to start with you, and I want to get some of your thoughts and your take on this because I know you've actually delved into this quite a bit.
So thank you, Sean. So we've known for roughly 15 years that every time the OIG does a review of Medicare risk adjustment data from a Medicare Advantage plan, that surprised there was over-reporting of acuity on a great deal of their population. And the reason for that is that anytime you have a high level of acuity or what they call an increased risk score, what tends to happen is you get a little bit more money from the Medicare program for quote end quote treating the sickest patients. So it's no, when you're dealing with publicly traded companies, it's not a, I don't think it is a bug, but rather a feature of the system that they're going to do as much as they possibly can in order to increase their acuity. Well, finally, after after about a third of my career watching Medicare just kind of sit on their hands and not address this, they've decided to address it in a large way. CMS announced at the end of May that they are increasing the number of investigators for Medicare risk adjustment data from 40 to 2,000. So that is a 50-fold increase that we're dealing with as far as people investigating Medicare risk adjustment data. Now, unfortunately, when we're talking about Medicare risk adjustment data, where the burden falls is not particularly on insurance companies. Unfortunately, the burden falls on medical practices with an increase in the number of Medicare risk adjustment requests that you're going to be getting in the mail. I just had a conversation last week with a small therapy practice that we deal with in the state of Georgia, where they now have had a request for 35 different patients for data for 2024. And that's a small practice in Georgia, that chances are doesn't really have a very heavy population of people and is focused on the treatment of one particular injury or illness for a very short period of time. And they're asking for a year's worth of data for all of those patients. And that's just one example. We've seen examples with rheumatology practices who are receiving hundreds of requests quarterly from the same carrier over and over again. So you do see an increase in requests. I'd kind of like to throw to the panel as to what the best course of operations is if this suddenly is becoming, surprise, surprise, an administrative burden on your practice in order to deal with these.
Yeah, I'll jump in real quick and I'll share with you some of what I've actually done. And Paul, you and Stephanie, I think you guys have seen some of the responses that I've sent primarily to our orthopedic clients, especially a big group that we have in the Southeast, where one of the requests that came in, and I want to say it was from Cigna, they asked for like 425 medical records at one time. And this was ongoing every single quarter. But yeah, Paul, I know the rheumatology group that you're talking about, and you're right. They were getting hit again and again and again. And we actually sent a notice back to the carrier, and we said, listen, what you are requesting is a significant burden to the organization. And what we would like to offer is for you to scale that back to a more reasonable number that we can actually comply with within the time frame that you're giving us, and then move forward from there. And I think, Paul, help me if memory serves correct, we went from like several hundred down to I think like 50 or 75 records on that request, and then they maintain that for like going forward. But
for now.
Yeah, for now. But I mean, listen, I think from my perspective, one of the key things that I hope you take away from this part of the discussion is, look, you have a right to engage in a meaningful dialogue with the insurance company to be able to say, we want to comply with you, but your request is overburdened. It's a burden to our organization. It is unrealistic that you are giving us 10 days, 15 days, even 30 days to respond to a request where we are not fully staffed at this point still, or we don't have the ability to give you access, and we're not going to give you access to our EMR system. And that was a conversation that Terry and I've had previously, especially with one of our favorite payers. But, it is okay to push back. It is not okay to ignore their request. It is not okay to say to them, we are not going to comply with your request, but it is okay to say, your request is a burden to our organization from an operational standpoint. We will comply with you, but we need something that is more realistic. And folks, don't forget, you have a path to file a formal grievance against these Medicare contractors by going directly to CMS and filing a complaint with CMS that you believe they are being, problematic and unrealistic in their requests, or they are creating a burden. Remember, CMS put out, the patient care before paperwork. Well, this is something that I think you could tie into that, because this is a burden to the practice. I know we're talking about doctors documenting in the medical record versus responding to a request, but guess what? A lot of providers say, hey, don't send my stuff off to an insurance company without first giving me an opportunity to take a look at it, so I understand what you're sending, so that we're sending a complete and accurate representation of the medical records that were requested from us. But let me pause there, because I think there's another side to this conversation that I want to get to in a minute. But let me go to Terry or Stephanie with some of your thoughts, please.
Go ahead, Steph. I'll take it last.
Okay. So, a couple of things, Sean. The point that you brought up is one that is actually high on my list that concerns me, and that's related to United Healthcare wanting access directly into practice EMR systems. And the problem is they're starting to essentially strong arm people in a way where what they're offering as or really in return for the access is something that people can't refuse. And I know Terry and I have had a conversation with a particular hospital that was like, look at this is how long it usually takes for prior authorizations or things like that. And as a result of allowing direct access in, that's going to significantly shorten the time and take away administrative time. So that concerns me because they already have so much control in the system. And now, they're going to use things like this to their advantage. Now, the other side of this, from the administrative burden part of it, I've already seen it heavily related to the claims process and the denials. So, we talked a little bit before about, them utilizing different technology, AI, all of that. And I've seen, with Medicare Advantage specific patients, where entire claims are being denied based on a combination of diagnoses that they're using. And when you go in to look at the combination to try to help with an appeal and see where that disconnect was, there was like an excludes note or something like that. So I know we've talked about that before as well, but you know, we already deal with practices who aren't really always closely following their AR. And then on top of it, we're going to have an increase in all of this. And who's to say as well that they're not going to do things like start to request records before paying a fee for service claim, which again is going to disrupt the revenue. So I think that we're going to see an impact on the AR side in addition to them just asking for documentation.
Yeah, and to add to that, to Stephanie's point too, I think just as in AI, there's not enough safeguards with certain payers, and I'm just going to put it out there. United Healthcare is a monster. I mean, I do some of their education, so I understand how big they are, and I've done audits for them too. So, after Change Healthcare and that nightmare last year, you just really understand that there is so much going on from just one payer. Just think about the other payers too, where they have, people don't realize, for example, if you get an audit request or a take back request from Optum, that's United Healthcare. So there's these carve outs. They don't realize where some of these companies that aren't called United Healthcare are actually that other company. But I have seen, going back to that payer platform, they call it. It's mostly tied to Epic and to NextGen, but they want all access, not even limited access to records, and not just for their own patients. And I talked to clients about this that don't do it. Like, yeah, but it's just so much easier just to go ahead and give it to them, and then we'll deal with it later. I'm just like, are you kidding me right now? First of all, that's a HIPAA violation to give them people's access that isn't their subscriber. But the other thing is, you give anybody access to anything, they're going to find a problem, especially if it means that they're going to get money back, or they can find anything if it has to do with money. Always follow the money. And so, just listening about, I think it's important that the government has finally stepped in and said, yes, we need to look at this because it's a problem, but be careful on how you respond to these audits. Be careful on what you do for them, because they're actually, Sean, this is something that your your audience may not know, or our audience, is that they're holding providers hostage when they want that access. They're like, well, how about this? If you give us access, then we'll make your prior authorizations easier for OT, PT, and for certain therapies. What was the other one that we got? OMT therapy. And I'm just like, what? They said, yeah, they're telling us that if we give them access, then they'll give us something. And so, uh, I mean, Paul, I mean, I'm at a loss for this. Going, okay, so now not only being held hostage, is it bribes? I don't know what you call it, but it's
Yeah.
inappropriate in my opinion.
Uh, Insurance companies never give you anything. I started in
They don't.
this industry with 6.5 years on the insurance side. Nothing is given away. There's no such thing as a free lunch when you're dealing with an insurance company. And it's important to point out, you kind of talked about other carriers. With UHC, we're talking about a company that has 30% of the Medicare Advantage business right now. And given what's occurred in the space where other Medicare Advantage plans attempted to tie into pharmacy chains in order to broaden their footprint in places like retail care and things of that nature, and how it flamed out spectacularly. Uh, I would imagine that UHC is going to have a much higher percentage of that going forward. Uh, they have had a very rough year, beginning with the events in New York at their shareholder meeting, and then subsequent reports and financial reports that have come out. But to think that they are somehow not going to weather this storm, particularly when one of their biggest revenue spots is Medicare Advantage, is naive. It's only going to get stronger. And as it gets stronger, they're just going to keep asking for more documentation in order to keep those checks coming in.
Well,
Isn't it weird that they hold on prior authorizations for like cancer treatment over a certain age, or certain things that actually can cure, relieve a
No,
problem, but they pay
no.
for gym memberships.
yeah,
I mean,
silver sneakers.
yeah, I know. I
Yeah.
mean, my husband's on Medicare Advantage. He's quite a bit older than me, folks, just putting that out there. But I'm just saying, I also have to put that out there. But I'm just saying, he tells me all the time, "Oh, look what I get. Look what I get. I get $60 a
Mm,
month to get whatever I want from, CVS Pharmacy." I'm
yeah.
just like, "Okay." But then if it takes him 6 months to get an authorization, to get a hearing test or something. And I'm just like, "Okay, this is weird."
No.
Well, I want to go back to
I know.
something that we were talking about, and then we'll move on from this topic. It's important because a lot of folks always ask, well, what do they really care about these HCC codes? These risk adjustment scores. Why do these Medicare Advantage plans really care? Well, remember, CMS actually pays the Medicare Advantage plans what they call a PMPM, a per month per member fixed amount per beneficiary, which is based on risk factors that affect the beneficiary's health expenditures, right? So sicker patients with um, more conditions, higher complexities result in higher risk scores, and therefore they can get a higher per member or per beneficiary payment. The problem that we have seen, and I'm going to give you some examples of some enforcement actions here in just a minute. When these companies overstate their data, they inflate their risk scores by submitting inaccurate or unsupported diagnoses to receive these higher payments. And even on the payer side, it's referred to upcoding. The same thing that we see at the physician practice when they say you have coded a level 4, but it really supports a 2 or a 3. The same level of upcoding exists there. So think about this. Cigna agreed to pay $172 million to resolve False Claims Act allegations related to submitting inaccurate diagnoses to inflate their payments. United Health Group, Elevance Health, Kaiser Permanente, they're all currently involved in ongoing False Claims Act lawsuits regarding the accuracy of the diagnoses that they've submitted for their risk adjustments. Humana, Aetna, Emblem Health, they all underwent federal audits that found these insurers overcharged Medicare by an estimated $145 million through risk adjustment practices, although the government claims they're limited in the amount that they can actually recoup. Listen to this. Independent Health agreed to pay up $98 million to resolve their allegations of submitting invalid diagnosis to increase their MA payments. Soul Medical Group. So for me, we were talking about this before we went live with the program. These corporations are making tens of billions of dollars a year in profits, okay, collectively. Some are making, that by themselves, but tens of billions of dollars a year in profits. Do you think that paying $142 million is really making a dent in their bottom line when they're collecting tens of billions of dollars? Where I think, where I think we're going to see a change in the behavior is by the DOJ. Pam Bondi, if you're listening, this is where the DOJ needs to go after these individuals, and not only go after them for civil monetary penalties under the False Claims Act, but actually file criminal charges against these individuals. Because to me, in my humble opinion, these could potentially rise to the level of a scheme or an artifice. This could rise to the level of criminal intent. You know, you have something called the Scienter, you know, there's the mens rea, all these things. Don't tell me that there aren't brilliant prosecutors who could bring criminal charges against these individuals in positions of leadership at these Medicare Advantage plan groups. And the first time you put a few of these individuals, these culprits, behind bars for criminal behavior, I mean, why aren't they're going after physicians right now under the RICO statutes, under wire fraud? Why aren't we doing the same thing to the heads of some of these insurance companies who we know are working with intent to defraud the healthcare payer program? Because if it wasn't intentional, when they got caught the first time, they would have corrected that behavior. But yet they keep going because it's all been civil. It's all been settlements. First time somebody gets prosecuted and they get sent to prison, I think you're going to see people wake up and go, maybe we should curb our behavior. I don't know. Maybe I'm just a crazy one.
No,
Paul,
Sean, I've
yeah, go ahead,
actually
Stephanie.
seen, I have seen and talked with other consultants that have clients that are directed by an Advantage plan to submit an additional code on every claim for their members. And by submitting the code, there's a designated dollar amount, and they're reimbursed that with the understanding that that is to improve accuracy in the submission of their information. No idea how that is allowed, but things like that are absolutely
Yeah.
happening.
Yeah. Real
Well,
quick,
and
I want to welcome Scott to the program. It's been a long time. And Scott, I'll
Thank
give you
you.
the last word on this. And then I want to get to Terry's topics because Terry has some great stuff for us to go through.
Yeah, I'm glad I could get in and hear this. You know, I think the challenge that we have in our society that is no different with Medicare Advantage planning is, you know, once we have a program that gets put in place, everybody immediately says, well, how can we exploit this? How can we maximize this? And so we sell it to the patients by offering them cheap gym memberships that they may or may not use, you know, or those types of programs. We bottleneck their knee surgery, but you know they can go walk on the treadmill 5 times a week. And you know, how many times have I been on a call with a provider talking about HCC coding, and the provider says, "Well, somebody told me just add all these diagnoses for the patients for these conditions that are present for the patients." And they say, "Well, I don't manage that, but somebody told me just, you know, for this HCC, you've got to put all of these diagnoses down," which is a real fundamental misunderstanding of how HCC coding works. And you know, when you have the payers and their financial lever is these getting these diagnoses onto the claim, you know, if we assumed everybody was operating in good faith, which they're not, over here we have like, well, how important is it that we properly manage these patients by managing all the conditions that they have? And we have this great program now where we make sure that the patients have like dedicated, focused management of these conditions. And then over here we have, we'll just put all these diagnosis codes in and that like facilitates the payment, right? And somewhere in the middle, the question we try to answer is, you know, what is the appropriate amount of treatment for an HCC condition? So if I have type 2 diabetes, does each of my 5 doctors need to manage that? Like maybe, but maybe not. And we don't really have those kind of discussions. And what ends up happening with this, you know, as with a lot of government programs, is it's just sort of the latest trough, right? And everybody goes and sticks their snout in it and gets as much out of it as they can. And I think that the chickens are coming home to roost a little bit on HCC. And the only reason I say a little bit is because of what you said, right? Like if I have to pay 142 million of my billions in profits, right? To me, that's just the cost of doing business.
Yeah. No, great conversation. I hope our audience is enjoying it, but I want to transition over to another really important topic. And Terry, I want to throw this one directly to you because I know you have talked about this a lot. You've actually encouraged me to talk about this this week during my trip to DC. So I want to talk about the realities of what people are referring to as Medicaid cuts, right? So let's really talk about what these qualifications are, what they should be called, and how they are going to potentially impact everybody.
Okay. So it's a talking point for certain, political parties to say everyone's going to lose their coverage and it's, cuts, 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 and all this. Okay. So let's talk about the realities of what it is. First of all, Medicaid is a state program, okay, and it's different everywhere. We call it CalOptima, Medi-Cal in California, Access in Arizona. A lot of states still call it Medicaid, but what it is, it's actually welfare. It is for low income people, okay, and I'm going to define what that is, and also for certain groups of people for eligibility. And what it's supposed to be for are people who maybe are not Medicare eligible but are over 65. It's for blind people, it's for disabled people, pregnant and or single and pregnant, skilled nursing facility people, diagnosed of mental health patients, medically frail, patients. It's even people that are qualified for caregivers for family members and children who are disabled or need their assistance. So the poverty level currently in the country is for a family of three, anyone who's making under $25,820. They also tend to be eligible. Now, as a state, okay, that based on how many lives you have in there, you're eligible also for federal funding to match a certain percentage of those funds. The problem is, and here's the big problem, and this is what the current administration is trying to get out of the Medicaid so that it is available and flush for people that I just explained who need it. They are right now under certain loopholes able to take that Medicaid funding and funnel it to other projects. They've done it in California to projects that have nothing to do with medical care. And so they're trying to get rid of that loophole. The other thing they're trying to do is they're trying to add work requirements. Now, this is tricky. Okay, I'm not saying I agree with it to a point, but it is tricky. So, work requirements also include it's called able body individuals, adults. Now, one party will tell you that 18 to 64, that's not what it is. Read the bill. It's 21 to 49. Okay, so that able bodied individual is 21 to 49, 80 hours a month. It includes school, job training, community service, so there's a lot of things that it includes as far as those hours. Um, it should, if that is enabled, it would save 109 billion federal dollars in savings, and it would basically affect about 15 million enrollees. It also, one of the other things they're trying to do, and whether you're whatever, again, political party you're affiliated with, whether you agree with this or not, it's trying to take between 1.2 million to 1.4 million illegal people off of the qualifications or eligibility roles. And so, where the tricky part gets in is if you have people who are on Medicaid, and this is tricky, that maybe do not have good internet connection or don't have a computer. Yes, there's still people out there that don't have computers. That and they don't have access to the portal to keep updating their eligibility, that they could lose their insurance. And so that's where that is an issue. But the biggest thing that's a problem right now is the fact that it's not necessarily, I don't like it called a cut because it means that the federal government is trying to take away money from that entity or that agency. No, they're trying to save money in there by making sure that the eligibility requirements are appropriate for people who need it, and they're trying to make sure that it continues to be flush or able to fund it from a federal level to the states where it's not funneled, it's not given to people who are not eligible, and it is appropriate for who needs it. So whether you like it or not, yes, some people will lose their coverage because they're not eligible. Now, by definition, is that a cut? Some people think it is, some people don't. I mean, it just, I personally believe there's a lot of trickiness and a lot of, red tape that goes into trying to make this work. But 17 states already have work requirements. And so one of the strongest ones, or I should say two of the strongest ones, believe it or not, are Arkansas and Georgia. And so you have to know what your state is going to do there. And but I don't want you to think that it's being ripped apart. It's not. It's being paired to make sure that our disabled, our blind, our children are covered. So just keep that in mind when you start hearing some of these things that on the television. If you haven't read the bill, and I don't know why you would read it, it's 2,487 pages. I mean, it's hard to find this stuff, but again,
Well,
and
you want to
Chanel
vote
brought up.
for it first and then read it, right?
I know, right? But it's hard. I'm trying to be very sensitive out, to everyone out there, and I'm trying not to make it political. But right now, that's all you hear about.
Well, I
Oh,
think you've done a very good job,
I'm
Terry, in all
trying.
sincerity.
So
I think it's important that people understand the difference between, a factual component of what's going on versus a mainstream media talking point, whether it's from this side or that side. I really don't care. The bottom line is it is an entitlement program. It is a welfare program. It is intended for a certain population. And unfortunately, for too long, the program has been taken advantage of all around the country, which has led to the instability that you see right now within the program, and to where you see certain individuals in one party working to try to do something to keep the program solvent, to find a way to keep the budgets intact, to be able to keep these programs working, and others who are screaming, or let me rephrase, others who continue to say, you're cutting, cutting, cutting. So, as I tell people all the time, there's always three sides to every story, right? Yours, mine, and somewhere in the middle lies the truth. This is why it becomes so critical as a civic duty to understand what's going on in legislature, to understand what is being voted on by your Congress people, your senators, your legislators in the state, so that you have an ability to have your voice heard at the voting box. That's basically what it is. But, I think, Terry, you did a very good job of explaining this and keeping it very apolitical. But unfortunately,
I know.
healthcare is a highly politicized industry. Whether you want to believe it or not, everything that goes on in this industry is tied to something politically.
Well, and I just want to put something out there to everyone because I've had to deal with this since, I'm 10 years younger than my husband. So he's on Medicare, I'm not. And so, I say that because I've always been on his plan. And so I had to go out and get my own plan. And this might put something in perspective for you. We have something out there called the Affordable Care Act. Okay, I'm sorry. I had to choke on that because what makes it affordable? My deductible for my own plan is $7,800. My copay for a PCP is $50 every time I go. I pay 780 a month for my premium. I rarely go to the doctor. I have my checkups or whatever. But you have to be insured. It's like car insurance, just in case something happens. And so I don't see the affordable part of that. So when they say cutting Medicaid, it's reducing Medicaid spending on things that will break the program, break the entitlement. And so be careful when you hear things like Affordable Care Act. It's not affordable. They just call it that.
Yeah.
I could get into other topics of things that they call things something that you're like, what? That's not what that is. But we won't. But I'm just saying, just be careful.
Yeah.
Try to read the material. Go to the source. I know it's tough, but we'd be happy to carve it out for you. But it's sometimes I think some of the information is skewed because people just clickbait and read the headline instead of the what's actually in it.
Well, let me go to Scott and let me get some of your thoughts on this, and Paul, and then I want to go on to another really good topic about these GLPs.
Yeah, I don't know what thoughts I have. I mean, I think in terms of how much money we spend on Medicaid, if I have $100 to go to the grocery store and the next week I have 80, Like that's cut, right? That means I'm going to have to decide in a different way, like what I'm going to buy. And so if a state decides to spend less on Medicaid, if a state or our federal government decides to, redirect or redefine eligibility, that's a cut. Now, is that a cut that should happen? Maybe it is, right? Like I don't, I think there's there's a gross amount of inefficiency in our healthcare system entirely, just in terms of how access to services is provisioned, and we talk about that on this podcast. Sometimes I think we see it in the work that we do, where I will have providers getting onto peer-to-peer orthopedic surgery reviews that are time and money wasting and preposterous, right? And it's still a healthcare dollar whether you spend it this way or that way. And so politically, I don't know. I think people similar to United Healthcare and Kaiser Permanente, or any healthcare insurance company that's getting fined for essentially like troughing Medicare Advantage, as we talked about a few minutes earlier. I don't know that I view that any differently than somebody who is claiming a Medicaid benefit, but they could work, or they're choosing not to work. Um, they're taking advantage of a system that is intended to provide to people who need it and using it on themselves, right? And so I think it's hard for me to decide who deserves something and who doesn't in that way. I think certainly I would agree with the premise that if you're an able-bodied person who can go out and work, like you should probably do that, right? And maybe there's a broader conversation about how companies offer benefits. I mean, there's a lot to that. I mean, to the extent I have concerns about Medicaid, I think when I think about my job and how I get paid, right? If money comes out of the system, I may work less, and maybe at this stage of my life, I'm ready for that, right? Could work less. Could it damage rural hospitals? Maybe it could. Like I don't know, right? But I think we as a country should be trying to figure out the most efficient and economical way to spend healthcare dollars. I think um, when you look at our health metrics compared to other countries if you want to say the first world or whatever, I think it's pretty clear our system does not operate in the most efficient, focused way economically. So if that's the case, we should be trying to change that.
Yeah. All right. Let's move on for time purposes. I want to move on to talking about these GLP-1s and really what's going on here, Terry, with the medications like Wegovy and some of these other ones that we're seeing advertised on TV. So let's kind of start talking about this, because I know this is a big area within a lot of medical practices right now
It is.
as an ancillary service.
Yeah, and there's a lot of practices that are trying to create weight loss clinics and lifestyle medicine and things like that. I know Stephanie had to fall off, but and this is really a lot of her area as well. But I'll just kind of in a nutshell, give you the information that I know and that I've come across with practices that are trying to do this. So, I understand that a lot of these, there are like we mentioned Wegovy because that's FDA approved. Ozempic isn't. And so if you
I didn't
are
know that. Really? Ozempic
yeah,
is not
yeah,
approved?
it's not approved,
Wow.
not for weight
Okay.
loss.
I just learned
So
something brand new. Wow.
yeah, not for weight loss. So
Okay.
one of the things, and also if you compound a drug, that is not approved either because they don't know exactly what's in it.
Okay, so the compounding I
Yeah,
did know
yeah.
about. I
So
just didn't realize that something that was FDA approved, but I guess it's now being used as an off label. They're not looking
right,
at it. Got
right.
it. Thank you.
Well, yeah, and so what's
Mhm.
happening is because these are so expensive. So for example, let's just talk about Wegovy for a second. That is FDA approved and is covered on insurance for obesity, but you have to also have some underlying issues, diabetes, whatever. One of the things that you have to be aware of is that monthly it's about $1,350 for patients to get this in the US. If you're in the UK, 79. In Germany, 49. So I've got all the stats on it. And I'm like, we actually, if some of it is manufactured here, we actually outsource this to other countries and they resell it. We buy it back at that a ridiculous price. So the HHS has gotten wind of this, and Secretary Kennedy's like, whoa, whoa, whoa. No, this isn't going to happen. And Dr. Oz is also on there. So people need to understand that these GLP-1s, so a couple things just real quick. What you're doing now, if it's FDA approved and the patient has a couple of underlying comorbidities with that weight loss, yes, they cover the E&M. Yes, they cover the if it's FDA, again, FDA approved the drug. But, okay, but in 2026, the proposed final rule that came out April 24th, it doesn't matter if it's FDA approved or not, they're not going to cover them anymore for weight loss. So they're not going to be on the formulary for coverage. So whatever you're creating, you'd have to have a cash pay price for that. The second part of this is, let's say you're using an off-label drug or you're using a non-FDA approved drug now, okay, and you are recommending it to patients or whatever. I'm finding that practices are still trying to bill E&M services for this because it's off label, because it's not FDA approved. That makes it experimental, investigational, which, if you look at what CMS says for medical necessity, nothing that's experimental or investigational can be reported. And that includes services surrounding that main service, including E&M. And of course, I'm getting practices saying, well, we're getting paid. It's like, yes, because they don't know what you're actually doing. And, Sean, you and I've always talked about that pay and chase. They will come back and take that money back at some point. So be aware of that. I don't want to go in too much into this because, I'm kind of touching the surface and this could be a forever conversation. But for those of you that are primarily using the drug therapy as your weight loss situation, that's where you can get into trouble. If it's other alternative, things that you're trying to do, diet, exercise, things like that, then you have other options. But when you start to get into the drug therapy, this is where it gets really tricky, especially because the government doesn't want to pay for these expensive drugs anymore. And so they said they took it for 2026, they're gone.
Yeah. Well, look, the medical necessity conversation is one that we can have for an extended period of time.
I know.
And I think we'll do that maybe in 2 weeks when we all reconvene. And I think we want to really talk about medical necessity because I think there's a lot of misunderstanding about how, I have a lot of folks, and Scott and Paul, Stephanie, Terry, we've talked about this. We have a lot of clients that have reached out and said, but Sean, why is it a problem if there's no LCD? Why is it a problem if there's no NCD, if there's no guidelines? Well, the thing to remember is, just because there is no LCD or NCD or NCA doesn't mean that this becomes the wild, wild west and you get to do whatever you want, however you want, whenever you want. There are still guidelines. Terry is talking about medical necessity, and the very first thing that it says, if I'm not mistaken, it's chapter 3 of the Medicare Program Integrity Manual. I think it's 3.2.3.4, somewhere in that area.
Yeah.
Okay. And what it talks about is, in the absence of an LCD, NCD, or LCA, medical necessity has to be the driving factor behind the ability to receive remunerations from the Centers for Medicare and Medicaid Services. And in order for something to be medically necessary, it cannot be experimental and or investigational. That's the very
also in
first
the Social
bullet.
Security Act. Yeah, it's also.
It is
Yeah.
1853 of the Social Security Act.
Yeah.
Yes. Or 1870. Anyways,
Somewhere around there.
it's in there. So I love having this conversation because so many practices have jumped on the weight loss protocol over the last several months, and these are providers that you would never expect would be adding these type of ancillary services to their mix, and they start prescribing all of these drugs, these Wegovy's, these Ozempics, whatever they are, and they've not done their due diligence on it. They don't understand that they are billing. And let me ask you this question, Terry, as an auditor, right, for both federal and commercial payer programs, right? Because you've done CMS audits. Okay.
Yeah.
If a portion of an overall service, right, which is the issuing of prescriptions for Ozempic, and I'm going to pick on Ozempic because you said that's the one that's not FDA approved for weight loss. And that's the only reason why the patient came in, was to have this conversation, and the doctor says, I'm going to put you on Ozempic. during a post-payment review, if the auditor, if Terry Fletcher, auditing on behalf of a federal payer program, looks at the documentation and sees the only reason why the patient came in today was to discuss weight loss options and the provider prescribed Ozempic, would you thus then
That
would you
negate the record.
then
Yeah.
determine that the E&M service was not medically necessary
Yes, I
because
would.
it is tied to a diagnosis of weight loss with a prescription of a substance that's not FDA approved for that
Correct.
treatment?
Correct. That would be considered non-billable service. They should have had a cash pay set up. It's experimental, it's investigational, and it's not approved. The other thing that I think people look at, TV is a scary thing because people are like, yeah, but I want to look like, that, celebrity or that Kardashian or
I would like
whatever.
to dance about my diabetes
I know.
at
And
the water fountain.
I know. And they basically want to look like, what's happening. I mean, I'm a plus size person. That would be cool, but I hate needles. So it's not for me. But I'm just saying that there's a lot of people out there like, well, they're getting it. They have millions of dollars. They're paying for it. So keep that in mind. And I get a lot of this is where we run into Sean, you're going to have a lot of work. I know you want to retire in the next 10 years. No chance. Not with this topic.
10
Because
years. I'm out of here in
I
5
know
years.
Scott's laughing, going, I know,
Oh,
I know what she's gonna say.
if I had $1 for every time Sean told me he was ready to
I
retire,
know,
I
right?
would be retired.
Well, here's the thing. This is going to trigger so many audits, especially with them taking off the formulary next year, because, and you're going to see Paul nod in a minute. I know he's going to nod, is because we see sometimes you guys mentioned it in HCC, we see the manipulation of what the patient's coming in for. So I'm seeing, they're coming in for obesity. They don't have, clinically defined diabetes. And they're like, well, let's just put it in as pre-diabetes so that we can try to get it through. No, 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 no. Or they try to give them some kind of chronic condition so that or comorbidity so they can put it through. And I'm seeing this and I'm like, stop. It's like saying somebody's old, so they're senile. You can't do that. And so you have to be very, very cautious with this. But I see this rolling downhill because, again, it's a moneymaker. But on the cash practice side, but the other thing that is frightening with all this is that it's almost like telehealth. Everyone said after we, kept getting extended every 90 days, they're like, "Oh, let's just be all virtual." And I'm like, "You guys, that was temporary. It was under a public health emergency." And now we're seeing this is, "Hey, look at how much these cost and look at what we can do." And now they're opening up these clinics, but they're trying to only get it through the insurance. And it's like you have to understand some things are cash pay. If the patient wants it, they're going to have to pay for it. And it's concerning because I just see a big problem moving forward. Now, here's just a thought, and then I'm going to put it out to the guys because I know that sometimes they have a good backup on this for me if I'm getting tunnel visioned. Since we do have a current administration that's trying to really lower costs for meds, if they can bring that cost down and reflect that that is actually scientifically through, they actually have evidence-based medicine that this is lowering A1Cs, it's lowering the risk of diabetes, it's lowering because it is, the side effects don't outweigh the benefits. I mean, let's face it, there are a lot of side effects. I know. See, I told you Paul was going to do that. Basically, there's a possibility it may come back and be covered, but not now, not at that 4,000 inflated cost. But again, follow the money. But at this point, you have to be aware of that. So Scott, I'm going to throw that to you because I know you see it.
I feel like the theme of today, for me at least, is like we just can't have nice things because when we try to have nice things, people take advantage of it and they drive up the costs. And, I actually, when I talk about obesity diagnoses with people and coverage, I mean clients and coverage of these meds and the underlying E&M visits, they look at me like I'm crazy. Like it's just like, what do you mean? Like I'm treating a condition. And the one thing that you had brought up, Terry, that I was going to ask you about because I struggle with it sometimes is, I'm very used to seeing obesity as part of treatment plans as sort of like, well, this will get me up to a level 4, so I'm going to write this very vague, like you have hypertension. Here's a very granular treatment plan for that. And you have obesity, and my treatment plan is like eat more vegetables. you know, and I think if you're treating something as a condition, treat it with the gravity that it deserves. And I've said to providers before, and this predates, frankly, these medications, where it's like, okay, the provider tells me, well, I treated two chronic conditions, diabetes and obesity. And I'm saying for obesity, you just told the person, try to lose weight, right? Tell
I know.
everybody
Well,
that.
and Scott, what about they keep moving the needle? Remember, what was hypertension used to be? It used to be, what was it,
I was
135 over
120
80?
over 80 is what it is now,
They,
I think, right? And
yeah, well, now it's 130 over 80, I think. They keep moving it, and so that I don't know, the pharmaceutical
oh,
companies keep saying it should be this. So now they're
my
saying,
doctor
a
My doctor
BMI
told
is
me that to
this, and
get
they're
me
going
on
to
a
keep moving
cholesterol
it.
medication. I was like, absolutely not. Like,
Yeah,
I
no,
will just
absolutely
eat
not.
better food.
Right.
Um, but I think so. There's a couple of things I would talk about, right? Like, one is like if you're treating this like a chronic condition, manage it as such. Like, get the BMI into the note, have a dedicated treatment plan that has specific measurables that you can use, right? But in reality, if this coverage is going away for these obesity medications, like these are not going to qualify as evaluation and management services.
Nope.
And the last thing I'll say about pharmaceuticals in general, and this will probably be my political comment for the week, is it always amazes me that every other country, we talked about the prices of some of these drugs in other countries, and I think even the president rather humorously referred to it a few weeks ago as the fat shot, in terms of like his friend getting it in England and paying less than he was paying here. And it never ceases to amaze me with these pharmaceutical countries that they will distribute all over the world for whatever price the government tells them they can sell it for. But then here they say, well, if you cut the price, we can't afford R and D, and everybody's going to die, right? And it's like at some point, like as an American taxpayer, I do feel like I'm subsidizing the world's consumption of these medications
Exactly.
as we pay exorbitant rates for them, and we get essentially like threatened, like, well, if you cut this price, you can't. And that's a little bit unrelated to the topic, but frankly, it's related to the extent that if we could price these drugs at a rate consistent with the rest of the world, we wouldn't have the same level of coverage concerns we have now. Because I think we are seeing, I'm seeing at least with some people in my family and just people I know, like the health benefits of these drugs are pretty tremendous just in terms of, there's side effects, there's all these other things going on, but people who, have struggled with their weight forever, suddenly are doing very well, right? And I think as a society, when you think about like what do you want the government to do for you as a human being, like help you with the tools to be like a healthy, functional member of society, right? So
Right.
anyway, I will yield the floor on
Yeah,
that point.
I want to give Paul, because I know Paul's going to have some great commentary for us on this one. So I want to give Paul. I want to give you the last word on this.
Well, and like so many different things in the world, I always go back to my Rod Serling, and I always go back to that one episode of The Twilight Zone called The Man in the Bottle. It's not the wish that kills you, it's the consequences of the wish. You know, uh, I don't think we know half the side effects of these drugs right now. We
Well,
get
they came
these,
on so quick, right? I mean, they
yeah,
came out of nowhere.
we get these amorphous things like, oh, you have Ozempic face, or I think the
Is that a
funniest one,
compliment or not? I'm not sure.
yeah, you
I
know,
know. I don't think so.
yeah,
Eye rot
yeah,
was something I heard.
you know,
Eye rot.
yeah,
Iron.
yeah. Well, and we mentioned the dancing diabetes drugs. I mean, if you listen to the side effects of that, one of them is a skin infection of the perineum.
Oh.
And I have a very slang term for that I can share with you from Philadelphia, but class and dignity spares me from sharing that in this forum. Email me at all available emails to get a good piece of my mind. But I mean, we're even, as you said, a lot of these drugs came on very quickly, and we are in an undiscovered country right now. I mean, we truly don't know exactly what the long-term side effects of this are going to be. Anytime you alter the body chemistry. I mean, it's going to be somewhere between an increase in a disease we didn't see coming and turning people into the X-Men.
Well, it's the same thing
It's
with
somewhere between
it's
that.
the same thing with right now cholesterol medication. So it helps people, but then it also can inflame your joints. And I was on one. My labs came back perfect. I don't have high cholesterol anymore. I've been doing the right thing, and I want to be off it. He goes, "Well, my doctor loves drugs. It's really sad." And he's like, "Well, you should probably be on it just for preventative." I'm like, "I'm not going to take drugs for preventative if it's hurting my shoulder." He goes, "Oh, are you having inflammation?" I'm like, "Yeah, frozen shoulder, and it's making
Here's
it
some
worse."
meloxicam.
I know.
Take
And
that too.
he goes, "Well, then we can add this one." I'm like, "Stop." So I said, "Can I please be off the statin?" And he goes, "Okay." My shoulder doesn't hurt as much anymore, and and I still don't have high cholesterol. So it's interesting because, like you said, we don't know the long-term
I
effects.
I have to tell you, I pride myself on taking like no prescriptions regularly as I get older, and as I try to run and work out and things like that, and I've had multiple bouts of tendonitis this year, which I think is because my age starts with a 5 now, and they did give me meloxicam, and that quiets me down. Like that's like only like 2 or 3 days of it, but it is like the best inflammation takedown.
Well,
Well,
Like,
well, go ahead,
I'll
Paul.
just have one last statement. I'm also in an age where it begins with a 5, soon to be beginning with a 6. Uh, I know you're I know you're a marathon runner, and I'm telling a lot of people this who love playing pickleball as they reach their sunset years. If you're doing anything that vaguely resembles a stunt, you need to stop doing that immediately. You'll feel better.
Pickleball is the number one injury thing for anyone
my
over
I
Yeah.
45.
I
It's
have
like,
a friend who has run more marathons than I have, and he tore his ACL playing pickleball. So it's
oh,
just a
geez.
different stretch or something.
Well, I want to go back to something that Terry was saying, because I think all of us start with a 5 on this program, and I am learning that just because the brain says yes, I also have to think about the consequences for the body.
You're the youngest
Hello.
one. You're the baby of the podcast.
Yeah. So, you were talking about physicians prescribing drugs and Paul, the unknown long term effects. You know, I've been battling, heart disease now for 5 years. And I will say this: I had my functional heart cath earlier this year. Um, Most incredible doctor. He's at Emory University's chief of cardiac, Wissam Jabber. And this was the most amazing thing to me. When when I first went to him about 2 years ago, after the stents that were put in, one of the first things he did was to sit down and look at all of the medications that these providers up to that point had been putting me on. And I think I was somewhere between 10 and 12 pills per day for my heart, right? In the first visit, he cut out 6 of those pills on the very first visit. And he said, there's absolutely no cause for this. Zero. And he went through, and I said, but why would the doctor? And he said, I don't care. I could give you every clinical explanation in the world for why somebody would want to do something. It doesn't mean that it was correct for you. Let's look at the history of your labs. Let's look at the history of when you've had these multiple stents put in and what they're saying. So for me, I love finishing this conversation with this: advocate for yourself with your healthcare. Ask questions. Ask the providers why. Why do I have to take this? Why do you want to add this when I'm already having problems with this? Aren't we just masking the symptoms? What is the rationale? Try to get to it. And if you're not happy with the answers that you're getting, do what I did: find a different doctor who is not a yes person, but somebody who has the compassion to understand what somebody at my age now, 51, is feeling and what my long-term goals are, and then looking at each medication and what their adverse effects are, looking at what the long-term use of these drugs could do to an individual, and engage. You have to ask questions, engage. And hey, for the doctors, you want your patients to engage because guess what? Aren't E&M services right now either based on the total duration of time that you spend with a patient or the medical decision-making process? Well, hey, you got both options to choose from. So do the right thing. All right. I want to thank Paul Spencer, Scott Kraft, Terry Fletcher, Stephanie Howard for joining the podcast today. Stephanie had to drop off, but everything is good. She'll be back with us in a couple of weeks. Scott, Paul, Terry are going to be back with us as well, hopefully in 2 weeks. Terry and I are going to be back tomorrow with an all brand new episode of our hashtag Terry Tuesday on the Compliance Guy. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care. All right.